Good evening, viewers. Good evening, doctors. Welcome in our session of Hydration in Diabetes series. Today is the sixth webinar, and we are going to have a very interesting session today on water and diabetes complications. Before I introduce our guest speaker and mentor and our guide, Dr. Sanjay Kalra sir, I would like to announce the names of the winners of the last episode. So, can we have the names of the winners of the last episode, please? So, the winners are Dr. Sanjay Mehrotra from Uttar Pradesh, Dr. Girish Jasota, whom I've met, I think, 2 days back in Ghatkopar. Welcome, Dr. Girish Jasota, and Dr. Hitesh Vora, again from Maharashtra. Congratulations, doctors. And another reminder I would like to put is this, that we have started our journey with 52 weeks Diabetes Essential with Dr. Sanjay Kalra in memory of Dr. K.K. Agarwal, season 2. And in that, the beginning was a grand beginning where we could get the time and the blessing and the wisdoms of Dr. Vivian Fonseca, and he could spend around 50 minutes speaking on cardiometabolic health and cardiovascular disorders in diabetes. So, anyone who has missed this session, I would strongly recommend please go through the link which is coming to you regularly on every Sunday night at 9 p.m. or before that around 8:30 it comes to you as a reminder for 9 p.m. show. Say in the same link, when you put your email ID and log in, you will see the first lecture is of Dr. Vivian Fonseca, and I'm sure anyone who has missed it, please log into that. And also, I would remind that there would be one more. There would be last hydration in diabetes session, which will be on 13th of May, and with that we will be closing our series of hydration in diabetes webinar, and we will continue with our 52 weeks diabetes essential. With this, I introduce our mentor and our uh, um, interviewer, Dr. Sanjay Kalra sir, who is the president-elect of Southeast Asian Federation of Endocrine Society, and he is the host of our hydration in diabetes. Welcome, sir.
Thank you, Mr. Basu. Thank you for inviting me.
Yes, sir.
This is a great opportunity to connect with everybody. And sometimes you connect over maybe an alcoholic beverage, a non-alcoholic beverage. And India is famous for its cuisine, for its wide variety of beverages. Jaljeera, Nimbu Pani, Aam Panna, Kokum juice. These are all things, lassi, buttermilk. These are all things which come from our Indian history. But the base that all of them contain is something known as water. So let's connect today over a glass of water, over a glass of cold, cool, chilling, and refreshing water. And I appreciate this opportunity to be with all of you together. We are in this series of hydration. We are talking about water. And when we began working on this topic, when we began discussing it, we realized that there is much, much more to water than just a couple of molecules of hydrogen and one molecule of oxygen, H2O. There's much more than that. We appreciate all the comments and questions that have come in. And taking this discussion forward, today we have with us Dr. Atul Dhingra. Dr. Atul Dhingra is an endocrinologist from Sri Ganganagar in Rajasthan. This is the westernmost point almost of our country. So, Dr. Atul, what is the temperature in Sri Ganganagar and in Rajasthan these days? It's we need to unmute. The same way, like in summer, you get heat stroke. So yeah, so even the Zoom gets heat stroke. Okay, now it's fine.
Yeah. You asked a question. Can you please ask me again? I had some internet trouble.
What is the temperature? So we are all gathered with each other today over a over a glass of
So-
chilling and refreshing water. What's the
Yeah,
temperature
yeah,
in Ganganagar?
So it's usually around 40. Today it was around 42, 43, and it touches 50 on some days. Uh, we are we have extremes of temperature here in Ganganagar. During the summer season, we are the hottest in the plains, and during the winters, again we are coolest or the coldest in the plains. So we are living in extremes of temperature over here, and it's really very hot. And I believe this topic is really pertinent, especially with the temperatures with which we are living today.
And the temperatures are going up and up in summer.
Yeah.
So,
Yeah.
Dr. Atul, we've been in this series of hydration webinars, and we have been learning more and more about water, about dihydrogen monoxide. There is an English word known as Azonerism. How did Azonerism come into being? There was this student called Zohner, and what he did was, instead of using the word water or instead of using H2O, which we all understand, he used the word dihydrogen monoxide, and he listed all the negative points about DHMO, and he asked people to join him in petitioning to ban DHMO, and so many people did that. They didn't realize what DHMO is. The things that came to the fore was, one was chemophobia. People are afraid of chemicals. Second is just a herd mentality or sheep mentality. Whatever you do, people will do that. And if you are able to couch it in scientific sounding words, then it becomes more impressive. Now, this issue of Zohnerism we find across the social media today. But let's talk about water today, and let's focus on diabetes. So, if Dr. Atul, if you could switch off your camera, please, that will make your voice much better.
Yeah.
Yeah.
I think
Right. It is much better now. Yeah. And if you'd like to speak about diabetes and water today.
Yeah. So, should I share some slides?
Sure. We can share them from the backend.
I'll try if I'm able to do it.
Yeah. Fine. We'll go ahead. Next slide, please.
Yeah.
And
So,
the next slide.
We'll be talking about water and diabetes today, like Dr. Kalra was saying that with temperatures soaring up and up, I believe it is one of the things that is really important, especially with these temperatures. It not only improves dehydration, but in next 10 or 15 minutes, I'll be telling you how it helps in improving diabetes. Water helps in preventing diabetes, so it helps in primary prevention, it helps in secondary prevention, and it also helps in tertiary prevention. Today we'll be discussing about primary and secondary prevention. Primary prevention being how good intake of water can help in preventing development of diabetes, and how if even in diabetic patients, if water intake is good, how it helps in reducing the complications associated with diabetes. So this is what we'll be talking about in next few minutes. Next slide. So there is an intricate relation between hyperglycemia and hydration. We all know that it is the kidneys that alters fluid reabsorption, and once there is an increased amount of glucose in the blood, it leads to increase in osmolality of the blood. And once glucose saturates the carriers that are associated with reabsorption of glucose from the kidneys filtrate, which is also called as glomerular filtrate, then this excess amount of glucose is passed in the urine. This glucose does not pass alone. It takes water along with it, and this leads to excess water loss, which is also called as osmotic diuresis, and this can lead to dehydration in a diabetic patient. Next slide. So if we look at the impact of hydration, it helps in prevention of diabetes. I'll be telling you how hydration is associated with diabetes. What is the amount of disease burden that can be reduced just by having a good hydration in any patient. It helps in control of diabetes, and this we see in our patients also. If we have patients admitted with very high blood glucose, the first thing that we give to that patient is fluids, so that the dehydration part is taken care of and the blood glucose starts settling down just by improving the hydration of that patient. Not only this, improving the hydration also helps in preventing the complications associated with diabetes. Next slide. So, uh, low water intake has been shown to be associated with increased risk of development of diabetes. So, this was an interesting study where the authors tried to look into this relation, and they tried to calculate according to the daily water intake, and then they tried to look into the odds ratio of developing new onset hyperglycemia in those patients. So, in the study group, there were around 3,000 middle-aged men and women were studied in this study, and during the follow-up, there were around 565 incident cases of increased blood glucose. And the authors showed that this increase in blood glucose was negatively associated with water intake, daily water intake. So if a person's water intake was on the lower side, there were higher chances of developing hyperglycemia. The authors concluded that water intake is inversely related with the development of hyperglycemia, and it is an independently associated risk factor. They further showed that it is the vasopressin hormone, which is also known as antidiuretic hormone. It is an important factor for glucose homeostasis, and this low hydration status alters vasopressin secretion, and this is associated with increased blood glucose levels. Next slide. Vasopressin acts through multiple pathways. It Once the water intake is reduced, there is an increased secretion of vasopressin, and if we remember physiology, vasopressin is also a stimulator of ACTH production. ACTH is the hormone which is also called as adrenocorticotropin hormone. This is associated with increased release of cortisol. Cortisol is our stress hormone, and increased cortisol is associated with hyperglycemia. Further, increased vasopressin is also associated with increased glucagon secretion, and we all know that increased glucagon secretion leads to increase in blood glucose level. It not only acts on pancreas or pituitary, it also acts on liver. It increases gluconeogenesis and increases glycogenolysis as well. All of these changes lead to an increased glucose output, and this is associated with development of new onset hyperglycemia. Some of the studies have postulated that improving hydration status may lead to reduction of around 6% chance of having type 2 diabetes. So studies have quoted that reduced intake of water deteriorates glucose regulation, and improving hydration can actually help in preventing development of diabetes, and this can be to the tune of around 6% or so. So clearly, water intake helps in primary prevention. Next slide. So if we look at the water homeostasis and what actually is dehydration. So dehydration can be because of water loss, or it can be because of both salt and water loss. Water loss produces an hyperosmolar state, and this can be purely a hypernatremic state, which is because of loss of water itself, or it can be hyponatremic state because of hyperglycemia, which is seen in diabetic patients. We all know that once blood glucose increases, this leads to a increase in plasma osmolality, which is associated with hyponatremia, and this further leads to an increase in blood urea nitrogen and creatinine ratio. So there are some of the reasons associated with this increased ratio, and hyperosmolar dehydration is one of the reasons for this. And in this setting, these patients should be replaced with hypotonic fluids. Salt loss, if there is a predominantly salt loss, this leads to an hyponatremic state, and again the osmolarity is on the hyperosmolar side, because not only the body is losing salt, but it is also losing fluid along with the salt. And again, in these patients, isotonic fluids should be given to improve the dehydration part. Next slide. How hydration helps in diabetes? Hydration improves the plasma volume, and this increased plasma volume is associated with lower blood glucose concentration. It reduces the arginine vasopressin secretion, and I showed you previously that increased AVP secretion is associated with physiological changes that are associated with increased blood glucose concentration. Further, there is a reduction in gluconeogenesis, there is a reduction in osmolality, there is an improvement in cell volume, and all of these factors result in improved glucose metabolism. Some of the studies have shown that experimentally induced dehydration promotes development of hyperglycemia. Even if you are treating patients with diabetic ketoacidosis or hyperosmolar coma, you'll see that in the initial part, because of severe dehydration, blood glucose are in very high range. As these patients are hydrated, their blood glucose start settling down, and the requirement of insulin also reduces over the time. Next slide. So there are certain factors that are associated with dehydration in the diabetic patients. Most commonly, it is because of insufficient fluid intake. If your patient is undergoing strenuous exercise, and especially in our part of the country where the temperatures are very high, and if hydration status is not well maintained, then in these situations dehydration can set in. Certain medications like diuretics can also lead to dehydration. If the patient is indulging in too much of alcohol, this can be associated with dehydration. Heat exhaustion, like I was telling you, now in this temperature we routinely see many patients with heat exhaustion, and one of the rare causes of dehydration is diabetes insipidus, which is because of reduced secretion of arginine vasopressin. Next slide. How can we identify our patients with dehydration? So these patients are usually thirsty. They have some mild headache that is ongoing. They have dry mouth and dry eyes. Dizziness is, so many of your patients will be coming to you, and they will be saying to you that they are feeling dizzy, or they'll be saying that mujhe chakkar aa rahe hain. So these are actually the symptoms of dehydration. Tiredness is another very common complaint in our OPDs. If we inquire them, they'll give you history of passing of dark yellow colored urine, which will be suggestive of dehydration. And just by improving their hydration, these complaints can be improved. Next slide. If the dehydration persists, then the symptoms become more severe. The patient's blood pressure may fall. They have sunken eyes, and because of low blood pressure, their heartbeat increases. Tachycardia can be seen in these patients because of dizziness, and once this dizziness increases, they start feeling confused. The pulse rate is usually weak, and lethargy is also a component of severe dehydration. Next slide. So what are the electrolyte disorders which can be seen in patients with diabetes. It can be associated with sodium disorders, which are very common. I believe one of the most common electrolyte disturbances in a diabetic patients are sodium disorders. Hyponatremia being very common. Hypernatremia is mainly seen during treatment of hyperosmolar non-ketotic coma or diabetic ketoacidosis. Uh, Hyperglycemia is associated with hyponatremia. Again, osmotic diuresis may also be associated with sodium disorders. Potassium disorders are also common in diabetic patients, especially if you are giving these patients IV insulin. Hypokalemia is common. Uh, Renal and GI losses of potassium because of drugs or reduced tubular secretion of potassium is also associated with potassium disorders in these patients. Magnesium disorders, though not that common, but can be seen, especially in patients with diabetic ketoacidosis. Hypomagnesemia can be seen. You can suspect hypomagnesemia if your patient's calcium is not improving even on giving IV calcium. So suspect hypomagnesemia in these situations, and these patients might be having magnesium problems. Hypocalcemia is predominantly because of vitamin D deficiency, or if your patient is having acute or chronic renal failure, again, these patients can have calcium disorders. Next slide. So there can be different electrolyte disorders. Patients with diabetes, like I was telling you, the most common electrolyte disturbance in a diabetic patient is related to is related to sodium metabolism, and the term used for changes in sodium metabolism is dysnatremia. So it is a term that encompasses both hypo and hypernatremia. We know that hyperglycemia is associated with changes in serum osmolarity, and this leads to reduction in serum sodium levels, and this is associated with hyponatremia. Further, uncontrolled diabetes induces hypovolemic hyponatremia because of increased electrolyte losses. Use of use of diuretics and further osmotic diuresis is also associated with development of hyponatremia. We should always remember that we should, during the management of hyponatremia in a diabetic patient, we should look into the corrected sodium, which can be calculated as measured sodium plus a correction which is 1.6 divided by glucose minus 100, which has to be multiplied by 100. So this is how you can actually calculate the corrected sodium. And whenever you are treating patients with severe dysglycemia, corrected sodium should be used in those situations. Next slide. Other electrolyte disturbances related to calcium metabolism can occur, like hypocalcemia. Usually hypocalcemia occurs in a patient who has a malfunctioning kidney in a diabetic background. So hypocalcemia is seen in those patients. And like I was telling you, hypomagnesemia is another potential cause of hypocalcemia. Hypercalcemia is usually associated with increased intracellular free calcium concentration, and hyperparathyroidism is usually the etiology in this scenario. If you are seeing a patient with hypercalcemia, try to look into the PTH levels, and probably hyperparathyroidism is the etiology in that situation. Hypophosphatemia, the predominant cause usually is vitamin D deficiency. Other causes can be hyperthyroidism or use of diuretics. So if the patient's phosphate levels is less than 1 milligram per deciliter, in those situations, phosphate replacement is required. Next slide. So I believe we have 2 quiz questions today, and we covered this during my talk. select the correct statement. Low water intake has no effect on the secretion of ADH. Drinking water may lead to 6% less chances of having type 2 diabetes. Reduced glucose intake is not linked to glucose regulation, or low water intake suppresses CRH secretion. CRH is corticotropin releasing hormone. Can we go to the next question? What is the primary cause of hypophosphatemia? Is it hypothyroidism? Is it vitamin D deficiency? Is it use of oral anti-diabetic drugs? Or is it insulin resistance? So I believe this is from my side.
Thank you, Dr. Atul. That was a great presentation, and you shared so many aspects of water and diabetes. Let's try to paraphrase the entire spectrum. First of all, diabetes is a complex disease, multiple clinical presentations, multiple complications as well. And water can be used for primary prevention of diabetes, for secondary prevention, for tertiary prevention. So that is one thing that we understand. Second thing that we understand is there is much more to water than just H2O. There are so many electrolytes, so many solutes in water. And when you are managing water health, you cannot forget electrolyte health. And when we think of electrolytes, think beyond sodium and chloride. Of course, we will think of sodium, potassium, chloride, but do spare a minute to think about calcium and magnesium health as well, or balance as well. That's the second thing. And the third thing that comes across is when we speak of endocrinology, we always speak of feedback axis, negative feedback. Like you have hypothalamo, pituitary, gonadal axis, or hypothalamo, pituitary, thyroid axis. In water metabolism also, we have a reno-hypophyseal axis. So the kidney and the hypophysis, that is the pituitary, the reno-hypophyseal system works in tandem with each other to ensure water homeostasis and to ensure good health. So Dr. Atul, thanks for that. I think again the internet is playing truant, but Dr. Atul is back. So maybe we can try the video also now, Dr. Atul. Lots of questions coming in for you. Dr. Bindu Bijlani has a question. Is hydration related to EGFR? Will the level of hydration impact serum creatinine? Will it impact blood urea nitrogen?
Yeah, so I think it's really a very important question. Hydration is definitely related to EGFR. If you see your patients with the acute gastroenteritis or who are dehydrated, their EGFR reduces. And if the relation of nitrogen to creatinine increase, increased more as so during hydration is one of the reasons of an increased ratio of nitrogen to creatinine, and dehydration is associated with reduction in EGFR.
So let me just repeat what Dr. Atul said because the voice was not very clear. Hydration is related to EGFR, and we thank Dr. Bindu for raising this point. Now, in general, the impact on blood urea will be more than that on serum creatinine, but that is a very general statement. When you have acute kidney injury, there are different causes of acute kidney injury. It can be pre-renal, renal, and post-renal. So, Dr. Atul, from an Indian perspective, what are the common pre-renal causes of acute kidney injury? Yeah, the voice is not coming all that clear, but many things, and right on top would be dehydration. Whether it is because of lack of intake of water, or maybe because of too much of loss of water. There can be only two mechanisms for dehydration. Lack of intake of water is when there is lack of appetite or thirst, or lack of availability. You are thirsty, but you don't have any water to drink. Loss of water, either from the urinary tract, polyuria, or from the GIT, diarrhea, or from the skin, too much of sweating. Dr. Atul, other comments? What are the... yeah, now your voice is fine. Would you like to continue with the discussion? Hydration, EGFR, pre-renal, acute kidney injury.
Telling, I believe pre-renal dehydration is the most common cause, and especially in with the today's with the temperature which is seen in summers in the northern part of the country, I believe the spontaneous loss is one of the very common reasons of dehydration, especially in the elderly patients. Both the extreme age groups, elderly, as well as the toddler age group, both of the extreme age groups are more prone to dehydration, and spontaneous loss is one of the most common causes of dehydration. And like you were telling, causes as well as gastrointestinal causes are available.
So Dr. Atul is raising the point in very young children up to toddlers, and also in the very elderly, the risk of dehydration is more. In the elderly, the thirst mechanism is impaired. So we spoke of the reno-hypophyseal system, the feedback, but if you just look at the hypophysis per se, the thirst mechanism is impaired in the elderly. So you have to keep on reminding them to drink water regularly, even if they are not feeling thirsty. Dr. Malathi Ramesh has another point, and would you want to discuss this one by one, Dr. Atul? The question is, when patients suffer from gastroenteritis, can they take antidiabetic medication or not? So if one by one, you could describe all the antidiabetic classes of drugs and which one can be taken, which one should be avoided. So, Dr. Ramesh, that is a very pertinent question. If the BP is normal, patient is able to eat adequately, patient is passing enough urine, then in general, all the medications can be given. But now there will be two issues with gastroenteritis. One is a GI upset. The GI upset is so much that patient is not even able to eat food or digest or absorb food. Then how will the patient absorb or digest the tablet? So in such cases, the offenders like metformin, acarbose, voglibose, they should be reduced. And if things are very bad, you can also discontinue for a day or two. Glucose control will come later. The first thing is symptomatic relief. Now, supposing the gastroenteritis is not so bad, symptom-wise, but because of that, we have dehydration, and there is a risk of acute kidney injury. Then the least that we can do is to prevent further dehydration. So here we should stop the SGLT2 inhibitors, like empagliflozin, dapagliflozin, canagliflozin. No harm in stopping for a day or two. Usually these drugs are being given for long-term CV benefit. So the long-term CV benefit will come later. First, again, we need symptomatic relief. So for me in my OPD, if I have a patient with stable, with gastroenteritis, whose hydration level is stable, blood pressure is stable, I usually continue all the medications. But if the patient has extreme symptoms, patient has hypotension, patient has decreased urine output, decreased water intake, food intake, then I will discontinue the SGLT2 inhibitors. If patient has severe symptoms, then I will consider reducing the metformin dose. And we will keep on reminding our patient to take small, frequent meals. Sometimes patient will say, I am not hungry, I don't want to eat the food which I normally eat. Then they can relax, they can take a little more fruit, they can take more fruit juice, it really doesn't matter. Instead of taking chapati or rice, they might want to take buns, small pieces of bread dipped in milk. They might want to take curd. Low calorie foods that you can give would be a fruit raita, not fruit cream. Cream would not be a good idea, but a fruit raita or fruit and buttermilk, these are things which you can suggest to your patient. Dr. Atul, a question and greetings also for you from Bhillai in Chhattisgarh from Dr. Anshul Singhai. So thank you for such a wonderful topic. Thanks for your talk. And electrolytes play an important role in dehydration. So how do we ensure good electrolyte replacement when we are managing or when we are preventing dehydration in the OPD?
Managing, electrolyte definitely plays an important role in managing dehydration. Like we were taught during our MBBS days, the oral dehydration solution is one of the good ways, especially in situation where we understand that both fluid and electrolyte loss is massive. In those situations, using a oral dehydration solution which is easily available is useful. Like you was telling, uh, the, the common that we give our patient is, especially in the summer season, they can take buttermilk, ablicum, most of the times we reduce their antihypertensives. We shift our patients from diuretics to a non-diuretic containing antihypertensive, so that the dehydration is reduced. And we also become a bit liberal in the salt intake during summer season, especially in our part of the country. So these are the practical things that we usually do in our patient.
So thank you, Dr. Atul. And just to repeat, number one, be proactive, especially in summer. Encourage your patients to take local beverages like buttermilk, chaj, nimbu pani, jaljeera, kokum juice. These are different suggestions for the patients, and you suggest whatever is economical, whatever is available locally. Second, reduce the dose of electrolytes, and this I see all across North India. In summer, our doses of antihypertensives come down. In winter, they go up. I also know that our colleagues in South India do not experience this because the weather is the same throughout the year. But still, do keep in mind. And if your patient is complaining of easy fatigability, then first thing that you would want to do is want to reduce the diuretic dose or maybe stop it also for some time in summer. How do I explain the concept of heat exhaustion to my patients and how do I manage it? Now, we come from an agricultural belt. Dr. Atul is also from agricultural belt. And all our patients, all our farmers, they buy huge quantities of rock salt. And they just put those slabs of rock salt in front of their cows and buffaloes. So the cows and buffaloes are allowed to lick the salt ad libitum, like Dr. Atul said, as much as they want. And then we ask them, you are giving so much of rock salt to your animals because you love them, you want to take care of them. But how much of salt did you take yourself? You went to the farm, you drank a lot of water because you were thirsty. You drank it from the tube well, but you remained thirsty. Your thirst did not subside. The reason is that you did not take care of your reno-hypophyseal axis. Your hypophysis was actually telling you a message, take electrolytes. I am developing hyponatremia. But you didn't listen to that, so you just kept on drinking water and you ended up creating more hyponatremia. So once we explain this, it becomes easy. How do you handle that hyponatremia? We have good examples. So let's take, just for convenience, some names of brands. If you have a person with diabetes where you want electrolyte balance, then Enerzal Zero is a very good drug to use. How do I use it in my OPD? Patient comes in with ghabrahat, with weakness, energy, asthenia. Now, there can be so many diagnoses, but the commonest one is heat exhaustion or maybe dyslipidemia. So what we tell them, why don't you take a bottle of Enerzal Zero and sit and wait with us for 15 minutes. After 15, 20 minutes, we'll check your BP again. We might check your glucose if you want. And then let's see. If still the patient is complaining of uneasiness, chest pain, now that means I need to do an ECG. I need to investigate further. But 99% of the times, the patient is fine. Use those 15, 20 minutes for diabetes education, for general education. What you will see is the patient will become an evangelist, an ambassador for your practice. Because while the patient is going away, you can very slightly say, Madam, had you gone elsewhere, you might have been admitted, and then you would have got lots of intravenous glucose and other things. This is what you have done. Do not take the credit yourself. Do not say, I did it. But you say, Madam, see, you've taken care of yourself. Thank you for taking this Enerzel Zero drink that we suggested. You took the drink, you're fine, you're better. You've saved yourself from hospitalization. You've saved your family from the discomfort and inconvenience of hospitalization. Thank you, and we wish you all the best. And what will happen? The patient will go back into the community. She will speak with her neighbor, with her friend, and she will tell them, I went to that doctor. I went to Dr. Atul Dhingra and Dr. Anshul Singhai and Dr. Suresh Pawar, and they prevented admission. They were so nice. With a simple bottle, they helped me regain my health. So that is what you do. We call it VAT, value added therapy. Dr. Atul is very good at this VAT. So Dr. Atul, that was Enerzel Zero for people with diabetes. Supposing someone doesn't have diabetes, can you follow the same style of management using Enerzel Blitz? And what is your experience in your clinic?
So I'll tell you what I did in my days already, and it was really hard. And I'm still trying to switch on my AC because of I had to keep my doors open, and actually felt heat exhaustion. Exactly what you told 5 minutes back. Exactly that was what I was feeling, and I had a visit from a person and they actually gave it to me, and I drank that bottle in my OPD, and within 15 minutes I was rejuvenated, and I was again I started seeing my patients taking care of electrolytes. That is not available. So like you were telling, local fluids like buttermilk or kokum juice or whatever the jaljeera, whatever is available, that actually helps in that situation.
So thanks, Dr. Atul, for sharing your own experience as well. Enerzel Zero, Enerzel are always there. And another thing you can do is, I'm not sure about the rest of India, but here in Haryana, we get these 1 rupee sachets of Jaljeera powder. So we tell our patients to keep a few in their pocket during summer. So whenever they are unwell, whenever they are feeling a bit exhausted, they just have to ask someone for a glass of water, and they put that 1 rupee sachet in it. That 1 rupee powder does contain some sugar. So be aware of that, and you cannot give it to a person with uncontrolled hyperglycemia. More questions coming up. Dr. Apurva Biswas, thanking you, Dr. Atul, for all the information that you're sharing. And Dr. Suresh has a specific question. How do we take care of hydration of patients with diabetes and chronic renal failure?
So you have to look into the stage of renal failure that the patient is in, whether the patient is on dialysis or the patient is not on dialysis. That is one of the important things that distinguish upon the amount of water that can be given to a patient. Usually, what we tell our patient is to add around 500 to 750 mLs of water to whatever their output is, if the patient is on dialysis, or if the patient is developing edema, or if the patient is not able to excrete enough water. And 500 ml is usually the insensible water losses that occurs. But during summers, we expect that these losses are going to increase, so we add another 250 ml for those. So this is what we do. And if your patient is in stage 2 or stage 3 of chronic kidney disease, you can actually ask them to take water ab libitum.
Thanks. So, Dr. Suresh, to answer the question, if patient is on dialysis or has severe fluid overload, then you have to limit water intake. But otherwise, if patient is stable, no need to worry. A simple way would be you ask the patient to do a urine output charting, and roughly 1 liter per day per 24 hours, or 1 ml per kg per hour. That is another way of sort of looking at adequacy of urine output. But in extreme winter and extreme summer, we should be careful and we should ask the patient to be in regular touch with us. This very same topic which Dr. Pawar has raised, we will be discussing in more detail next week when Dr. Nitin Kapoor will speak to us about water and the complications of diabetes. So we'll be focusing on this in greater detail next week. Dr. Atul, when we began, we spoke of primary, secondary, and tertiary prevention. So would you again like to reflect on primary and secondary prevention of diabetes using water? And what insights does this bring for you in your clinical practice?
So, primary prevention actually means an intervention that helps in delaying the onset of that disease, or altogether it prevents the development of that disease. So, if, like I was telling you during my presentation also, that if a patient, if a person is well hydrated, then the chances of developing diabetes are reduced by around 6%. This is and this is a new onset hyperglycemia that I am talking about. So, and the pathophysiology behind this is that hydration actually helps in reducing the arginine vasopressin, the hypothalamo pituitary renal axis that we are talking about, and this further improves the body's physiology by reducing the ACTH level, reducing the cortisol levels, and reducing improving the liver metabolism, and thereby reducing hepatic glucose output. So this is how improving hydration helps in primary prevention. If we are talking about secondary prevention is that once a patient has developed diabetes, now by improving hydration, we are actually improving the patient's blood glucose level. I'll just give you an example. Think that you are having a glass of water, and now you're mixing a spoon of sugar in that glass of water, and on the other side you are having half glass of water, and you are mixing same amount of sugar in half glass of water. The concentration of sugar will be higher in half glass of water. So if your patient's if your patient is dehydrated, then even with same amount of glucose load, the patient who is dehydrated will be having higher glucose concentration in the blood, and this will be associated with complications associated with diabetes. So improving hydration improves complications by reducing blood glucose concentration as well.
So a strong scientific rationale, strong scientific backup for us to motivate our patients to drink more water. Now, this may seem so simple to many of us, but then this is how life is. Sometimes the most effective interventions are the ones which are simplest. And I'd like to thank Aditya Vardhan for also pointing this out, for highlighting the importance of water and electrolytes, and also the importance of the various products that we have discussed, which are able to replace both water and electrolytes in a very physiological manner. I'd also like to thank everybody who has logged in with us today. Friday night, weekend is about to begin, and it's almost 10 p.m. And the fact that we have so many questions, so much discussion, this highlights our interest, our enthusiasm, our energy when we are trying to work together to make India the diabetes care capital of the world, the healthcare capital of the world. I'd like to thank you all. Dr. Atul, if we could see you again, पर्दे के पीछे क्या है, and we hand back to FTC team and Mr. Basu.
Sir, I would like to thank Dr. Atul Dhingra for taking such a wonderful session, and Dr. Sanjay Kalra for moderating, as well as many a times we had discussed disturbances, so he could answer himself all the questions. So ultimately, we could get all the knowledge, which was the objective of the session. I personally feel that, because most of the literatures and the journals and the science which we read and which been taught in medical colleges are in the Western countries, where the weather is not like the tropical countries like in India. So when it comes to diabetes and the tropical weather in India, it is a very pertinent topic which Dr. Sanjay Kalra has started, and I'm very happy that with the kind of detail we have been discussing, diabetes intervention with the water is, I think, is going to be the topics which would be probably get importance and recognition in coming days in most of the sessions taken by dermatologists, because India is obviously a tropical country and we know better when we are having a session from Sri Ganganagar. Dr. Dhingra is maybe having patients coming with heat exhaustion and dehydration every day. Thank you very much. With this, I end the session and thanks Dr. Sanjay Kalra and Dr. Atul Dhingra. I personally feel I will be, this is my wish. I wanted to go and visit Dr. Sanjay Kalra personally, and I also had a wish to meet Dr. Dhingra. Maybe in coming, maybe 2-3 months, I will be coming and visiting you both personally. Thank you. Good night.
Thank you. Jai Hind.
Jai Hind, sir.